Hello colleagues, this is vascular thromboembolism prophylaxis in hospitalized medical patients. And this is me, Dr.يوسف Abdullah Hamid, the MRCP tutor, medical courses instructor from passonexam.com. My reference here is up to date. Why this topic is important? You have two reasons. Risk of venous thromboembolism is more than 50% of hospitalized medical patients. 2. Pulmonary embolism is the most common preventable cause of hospital death. So, how to approach those kind of patients? We have 3 steps to be followed. Start with step 1, thromboembolism risk assessment. Step 2, bleeding risk assessment. Step 3, selection of prophylaxis method. Let us start with venous thromboembolism risk assessment. We categorize the patients to 3, high risk, moderate, and low risk. If we start with high risk patients, we look for 3 things: critically ill patients, cancer patients, and ischemic stroke patients. Moderate risk patients who have at least 1 out of 11 risk factors for venous thromboembolism. Those are: 1. Old patients more than 60 years. 2. Heart failure. 3. Acute respiratory failure. 4. Renal failure. 5. Inflammatory bowel disease. 6. Sepsis. 7. Previous venous thromboembolism. 8. Prolonged immobility more than 3 days. 9. Obesity. 10. Inherited or acquired hypercoagulable states. 11. Pregnancy. Low risk patients, no risk factors for venous thromboembolism. Step 2, bleeding risk assessment. We look for intracranial hemorrhage, active GI bleed, and platelet count less than 50. Step 3, selection of prophylaxis method. For moderate and high risk patients plus low risk of bleeding, we start for them low molecular weight heparin, preferably, or unfractionated heparin if creatinine is less than 30. For low-risk patients, we advise for early ambulation with or without mechanical methods. For high or moderate risk patients plus high risk of bleeding, we advise for mechanical methods of thromboprophylaxis. Important note here, combined method low molecular weight heparin and mechanical are recommended for all patients with ischemic stroke starting at admission except in 3 occasions. Number 1, low molecular weight heparin should be delayed 24 hours after thrombolysis of stroke. 2. No need for low molecular weight heparin in patients with TIA or minor stroke who are treated with dual antiplatelet therapy. 3. No need for low molecular weight in patient receiving anticoagulation for another indication. So, which doses are recommended? For low molecular weight heparin, we have 2 dose adjustment for renal impairment and for obesity. For renal impairment, if creatinine clearance more than 30, will give 40 OD, or if creatinine clearance less than 30 will give 30 milligram once daily. For obese patients, more than 40 will give 40 BID, or less than 40 will give OD. For unfractionated heparin, we have adjustment for obesity. If body mass index more than 30 will give 5,000 3 times, or no obesity will give 5,000 BID. For fondaparinux in patients have HIT, if it is contraindicated if creatinine clearance less than 30, if 30 to 50 will give 1.5 milligram, if more than 50 will give 2.5 milligram subcutaneously once daily. Thank you. This is the end of this talk. Let us see you later in the next video.